In recent months, the world has seen unprecedented investment in new vaccines for COVID-19. A reminder about the value of vaccines in the prevention of disease. It has mobilized resources in an extraordinary way with over 100 vaccines and vaccine candidates under development. This first lung conference should show expansion of our R&D efforts, including R&D for TB vaccines. The title of the session is SARS-CoV-2, the hope for a new vaccine. We will hear from our speakers about COVID-19 investments, R&D initiatives, and the importance of communities. It is about advancing prevention. Let me remind all of us that this effort for research and development for vaccines, as Prime Minister Stefan Löfven said, is not the race about who will be the winner. It is about how we'll change the lives of those who have been affected and those who have been infected, and to prevent any further infections. I will take this opportunity to introduce our speakers, and the lineup is as follows. Firstly, we'll hear from Dr. Anthony Fauci, the Director of the National Institute of Allergy and Infectious Diseases from the US. We'll hear from Dr. Vasi Moti, the Coordinator for Research and Development at the World Health Organization. Dr. Suri Moon, the Co-Director of Research Global Health Center for Graduate Institute of International and Development Studies in Geneva. We'll also hear from Professor Jeffrey Lazarus, Head of Health Systems Team at Barcelona Institute for Global Health. And lastly, we'll hear from Dr. Kate O'Brien, the Director of Department of Immunization, Vaccines, and Biologicals, also from the World Health Organization. I would like to take this opportunity to invite the speakers to address us and hope that we'll have an interactive, vibrant session. Thank you.
I want to first take this opportunity to thank the organizers for inviting me to participate with a lecture in this 51st Union World Conference on Lung Health. It's a great pleasure to be with you. As you can see from this first slide, I've chosen as my title the public health and scientific challenges associated with the historic COVID-19 pandemic that we are currently experiencing. This slide is a cover of the Journal of the American Medical Association, in which my colleagues and I, in January of this year, wrote a viewpoint. You could see that the title of the paper is Coronavirus Infections More Than Just the Common Cold. By no means did I mean to be facetious with a title like that, but I just wanted to point out to the readers that we had been involved in dealing with coronaviruses for decades and decades. And let me explain what I mean. This is called a phylogenetic tree, which lists all the viruses that are connected molecularly. There are a number of human coronaviruses that are shown in red letters, but coronaviruses also infect bats, and bats and other intermediate hosts may be the major reservoirs of this. Now, as you can see in the 4 coronaviruses that are shaded in yellow, those are the 4 coronaviruses which, for an indefinite period of time, as far as we can gather, have been responsible for about 15 to 30% of all the common colds that you and I experience repetitively virtually every winter. They are relatively benign with few exceptions. Then what happened is that in 2002, we experienced the first pandemic coronavirus, SARS, or the severe acute respiratory syndrome, which emerged from Guangdong province in China, led to 8,000 infections and almost 800 deaths. A true pandemic, but given the fact that it did not efficiently spread, it was able to be contained by public health measures. And then 10 years later, in 2012, we had the second coronavirus pandemic, or MERS, Middle East Respiratory Syndrome, that originated in Saudi Arabia from a bat to a camel to a human. So we have now two diseases, the severe acute respiratory syndrome, again from an animal host, a bat to a civet cat to a human, lasted about a year and a half, contained by public health measures. Then MERS, we still have some smoldering reintroductions of this virus into the population, predominantly in the Middle East. But now we get to the present time, the third pandemic coronavirus, first recognized at the end of December in 2019, and then identified with its molecular makeup as a coronavirus in the first week of January of 2020, and put on this phylogenetic tree. You see it's very proximal to the original SARS virus, which then led to a renaming where the original 2002 SARS virus was called SARS coronavirus 1, and the virus we're dealing with now, with this unprecedented pandemic, is called SARS coronavirus 2. So getting back to the terminology, the disease itself is called COVID-19 for coronavirus disease 2019. And as I mentioned a moment ago, the particular virus is SARS coronavirus 2. So where are we now with this historic pandemic? It has exploded upon our world as the most extraordinary and impactful pandemic in the last 102 years, ever since the famous 1918 swine flu. So as of just a day or so ago, there were 38 plus million cases worldwide and over 1 million deaths. Unfortunately for us here in the United States, we have been the hardest hit country in the world, with about 215,000 deaths and close to 8 million infections throughout the country, with this heat map here showing with the darker colors the most involved sections and regions of the country. Now, we had somewhat of a different experience with Europe, which is now converging to be somewhat similar. Let me explain what I mean. If you look at the blue line, the European Union peaked a bit before we did, but when they came down to a baseline, their baseline was well below 10,000. Most recently, as shown on the right-hand part of the slide, as they get their colder weather also in the Northern Hemisphere, they are resurging with cases now of over 65,000 per day. The United States in red peaked predominantly early on, driven by the enormous number of cases and hospitalizations and deaths in the New York City metropolitan area. But when they recovered, other parts of the country kicked in, and our baseline, as shown in the red line, never got down to a low level. When we tried to reopen the country and reopen the economy, particularly in some of the southern states of Florida, Georgia, Texas, Arizona, and Southern California, we had a resurgence of cases up to about 70,000, which then came down, and now, unfortunately, we've plateaued again to about 40 to 50,000 cases a day. And as we're getting into the cooler weather, we're getting more and more cases. So this looks like we're going to have a very difficult fall and winter. But why did we not get down to the baseline that the European Union did? And it relates to the degree of closing that we did, the degree of shutting down of the country. You can determine that by GPSs on phones and measuring the mobility of people over time. As shown here, if you look at the United States in the dark line, we did not shut down vis-a-vis visiting to parks and outdoor spaces as much as Italy and Spain did, which serves as a representation of the European Union as a whole. If you look at workplaces, again, we did not shut down as much as the European Union. And when you got to things like visits to grocery and pharmacy stores, yet again, the lighter lines of Italy and Spain shut down much more completely than we did. Very likely one of a number of factors that led to this discrepancy. Let's quickly talk a little bit about transmission. This is a respiratory-borne virus, and exposure to respiratory droplets, as well as even aerosol, which are droplets that are small enough to hang around in the air for more than just a couple of seconds, and in fact, can infect people particularly in a closed room as air recirculates. The virus less commonly can be transmitted through contact with contaminated surfaces, and it's found in a number of body fluids, as shown on the slide: stool, blood, semen, ocular secretions, but the role in transmission is relatively unknown and likely not a major component of transmission. Animals, both pets and zoo animals, have been shown to be infected rarely. We do not think that this plays a major role in human infection. The risk of transmission varies with the type and duration of exposure, as well as the viral load of the person who's transmitting. Transmissions are seen in household contacts or in places where people congregate together and they don't have masks, referring specifically to cruise ships, nursing homes, and prisons. The factors that increase the risk of transmission include crowded spaces with poor ventilation, and even when people do simple things like speak or breathe heavily or even sing, so you don't need to be coughing or sneezing to transmit the infection. An important component that really distinguishes this infection from so many other viral infections is that about 40 to 45% of people are asymptomatic. And when you do modeling studies, a substantial proportion of the transmissions occur from someone who is without symptoms to an uninfected person. There are some fundamental ways to prevent the acquisition and transmission of SARS coronavirus 2. I have repeated this so many times publicly, but I think it worth repeating now. The universal wearing of masks or cloth face coverings, maintaining physical distance at least 6 feet, avoiding crowds in congregate settings, particularly indoors. Remember that outdoor functions are always safer than indoor functions, and frequent washing of hands is important. Let's take a look at the clinical manifestations. If you look at this slide, you see that very much resembles what we refer to as a flu-like syndrome early on. One difference is the peculiar finding in a certain percentage of individuals of a loss of smell or taste that precedes the onset of respiratory symptoms. Despite the fact that so many people, 40 to 45% without symptoms, when symptoms occur, interestingly, many of them, up to 80%, are mild to moderate enough that they don't require special medical intervention such as hospitalization. Whereas anywhere from 15 to 20% have either severe or critical manifestations, leading to a variability in case fatality from a few percent to as high as 20 to 25% for people who require mechanical ventilation. Some of these manifestations of severe disease, the most prominent is the acute respiratory distress syndrome. But as we learn more and more about this disease and its manifestations, we see that other organ systems, particularly the heart, with cardiac dysfunction, either as cardiomyopathy or as arrhythmias, sometimes leading to sudden death. Neurological disorders with stroke, in some cases of otherwise normal individuals, a peculiar hypercoagulable state of microthrombi in small vessels and thromboembolic phenomenon that can lead to stroke, acute kidney injury, and in children, a very curious multisystem inflammatory syndrome, very reminiscent to a disease called Kawasaki disease, in which children following infection, sometimes a couple of weeks later, can get severe inflammatory response leading to hospitalizations and in some cases intensive care. The people who are at increased risk for severe COVID-19 illness are older individuals. And if you look at a parameter such as the rate of hospitalizations per 100,000 population, the difference between young individuals on the left-hand part of the slide and elderly on the right-hand part of the slide is rather profound. In other words, younger individuals clearly do not get as many of the situations or clinical manifestations that make them severely ill. Many are without symptoms at all. This leads to confusion in understanding this disease because it can be relatively benign, if not almost non-existent for some people, and at the same time have a significant death rate among others who have underlying conditions. Speaking of which, people of any age with certain underlying medical conditions are at a high risk for severe COVID illness. These are the medical conditions that are clearly associated with an increased risk. I'll point out just a couple of them, although they all are relevant. Obesity is emerging as an important comorbidity. Diabetes, chronic obstructive pulmonary disease, and a variety of heart conditions. Smoking also looms large here. Those medical conditions that might confer an increased risk, but not as much as the ones on the prior slide, are shown on this slide. I point out a couple that are particularly relevant: hypertension, high blood pressure, diabetes, and overweight, not quite yet obese, but people who are overweight, as well as those with a variety of cardiovascular illnesses. One of the characteristics of this disease that's most disturbing is the extraordinary racial and ethnic disparity, where minorities such as African Americans, Latinx, Native Americans, Alaskan Natives, Pacific Islanders have a higher incidence of getting infected in the first place because of the nature of the jobs they find themselves in, putting themselves right on the front line, out in the community, contacting individuals, putting them at an increased risk of infection. But also, many of them have a higher incidence and prevalence of the underlying comorbidities that lead to a severe outcome. If you look at this striking graph here of, again, the parameter of the rate per 100,000 population of hospitalizations and compare Latinx with African Americans to whites, 368, 375 for the minority group, and 82 for the white non-Hispanics. Also look at the American Indians, the Alaskan Natives, and the Asian Pacific Islanders. Very significant health disparity here. Moving on to therapeutics, the NIH has put together a treatment guidelines panel made up of experts from throughout the country with experience in clinical management of COVID-19 patients. They meet regularly and have put together a living document accessible online at the website shown on this slide. And it's updated in real time regularly with new clinical data based on clinical trials as well as expert opinion. These are some of the therapeutics that are either in play or are being actually tested in clinical trials. Look at the lower half of the slide. I'll get back to the top in a moment. There are direct antivirals, convalescent plasma, which has been now given an emergency use authorization, but we still need to prove or not its efficacy in a clinical trial. Hyperimmune globulin, which is derived from convalescent plasma. Monoclonal antibodies seem particularly promising, as well as immunomodulators to blunt the hyperactive immune response. Take a look at two of these interventions that have been shown in well-designed and implemented randomized placebo-controlled trials. First, remdesivir, which is a direct antiviral, was shown in a randomized placebo-controlled trial in 10 countries, including the United States, shown that when compared to placebo, it significantly diminishes the time to recovery of hospitalized patients with lung involvement. Dexamethasone, a commonly used corticosteroid or steroid that we use for a number of diseases, in a randomized placebo-controlled trial in the United Kingdom of over 6,000 patients, showed that individuals with advanced disease, namely those requiring mechanical ventilation or requiring high flow oxygen, when compared to individuals who don't receive the drug, the dexamethasone group had a significant diminution of the 28-day mortality. This is now widely used with patients with advanced disease. Finally, vaccines. The United States has taken a strategic approach to COVID-19 vaccine R&D. What we've done is support directly or indirectly in the development and implementation of 6 vaccine candidates that I'll show you in a moment are in various stages of clinical trial. The strategic approach is to try and coordinate and harmonize the protocol, to have a common data and safety monitoring board to examine the data, common primary and secondary endpoints, and common immunological parameters to measure the correlates of immunity of the different vaccines. The United States government has invested billions of dollars in this process. These are examples of some of the vaccine platforms and the companies that are involved and where they are in the various phases of trials. There are 3 separate platforms: the nucleic acid, which is utilization of new technologies such as mRNA. There are viral vectors such as adenovirus and VSV, and the standard typical protein subunits. 5 of these 6 that we're supporting are already in phase 3 trial. 2 have actually gone into phase 3 trial on July 27th, and the numbers of people in this trial range from 30,000 to 60,000. And the way things are going now with the trials, we project that by November and December, we will know whether we have safe and effective vaccines, and I think there'll be more than one. One can never guarantee a safe and effective vaccine, but we are cautiously optimistic that we will have one based on preliminary encouraging data in animal models as well as in the phase 1 study. We project that by November and December, we'll have the answer, and then by the end of the year, in the beginning of 2021, we'll be able to distribute doses of vaccines that have been pre-ordered and made prior to even knowing they would work. So a major financial risk was done, but it would save time without compromising safety or compromising scientific integrity. So we would hope that as we get into 2021, we'll be able to begin to distribute vaccines in a priority first to those who are in most need of it, such as healthcare workers and those with underlying conditions. Let me close by showing this last slide, which is the link to the Coronavirus Prevention Network, which would give information about all of the trials that are going on. And if anyone is interested in participating in any of these trials, you can register your interest without any obligation in getting more information about how you might join. So once again, thank you for giving me the opportunity to make this presentation. It's much appreciated.
Good morning, good afternoon, good evening, everyone. My name is Vasi Morthy. I'm a senior advisor in the Science Division at the World Health Organization. The Science Division being a new part of the organization created by Dr. Tedros 2 years ago to further strengthen placing science and evidence at the heart of everything we do. It's really a privilege to be able to give this talk to the World Conference of the International Union Against Tuberculosis and Lung Disease. I've been asked to talk to you about the COVID-19 vaccine portfolio and some important characteristics for WHO that we would like the global community to bear in mind. This first slide shows the 5 main vaccine platforms. I've divided these into DNA, mRNA, protein subunit, viral vectors, and inactivated vaccines. And what we'll see if we look at the right-hand side of this slide is in the donut is that there are 42, remarkably, already there are 42 different candidate vaccines that are under evaluation for COVID-19. So there has been this amazing global mobilization of the vaccine R&D community, of manufacturers, funders, in order to make this happen. And WHO congratulates the community for getting to this stage. A couple of important points here are that in a way, there is a slight overrepresentation of the more novel types of platforms. So DNA, mRNA, and viral vectors. There are not so many of these that have examples which are licensed and available and are being used, but they're very promising for R&D, and we very much hope that they will come through. Whereas protein subunits and inactivated viral vaccines, there are many examples of these. So I think something that's important to bear in mind is what we see at the moment in the clinic is partly a reflection of how long it takes to get from the beginning of development to starting clinical trials, not necessarily the same as which ones are going to make it all the way through the pipeline, although we're very hopeful. So now with the next slide, we move on to the numbers of phase 3 vaccine trials that are underway at the moment. Half of these are viral vectors, which have moved very quickly into phase 3. 5 of them are inactivated viral vaccines. There is 1 mRNA and 1 protein, the mRNA being Moderna and the protein being Novavax. Now here, there is a focus on USA and Brazil, you will see predominantly, but still good representation globally. And we expect this situation to change rapidly as more and more phase 3 trials come on board. So on the next slide, this is an overview at the top of the normal way that vaccine trials progress through preclinical, phase 1, phase 2, phase 3. And at the bottom, you see that this normal sequential process has been very greatly compressed and merged so that the phase 1 and the phase 2 trials are rolling into each other. In phase 1, always the first time these vaccines go into humans, the focus is absolutely on safety. Then in phase 2, we start to look at the immune response more, what dose needs to be selected, what the interval is between the doses, and what the route will be for phase 3. And then in phase 3, it's primarily looking at efficacy against COVID-19 disease, as well as larger numbers for safety. And this is manufacturers, funders, regulators, ethics groups, clinical trialists, laboratory expertise, the data management expertise, all coming together in an unprecedented global effort to accelerate the timelines. Work that is just astonishing and very commendable. Now, I was asked to say a little bit about what WHO would like to see in terms of data that is generated from these vaccine trials. We have a document that's on our website known as Vaccine Target Product Profiles for COVID-19, so I would point you to this link. A few key points that arise from this and other guidance that we have. We consider that it's very important to demonstrate that the vaccines have worthwhile efficacy, not just any efficacy. So one way of doing this is ensuring that the phase 3 trials have enough endpoints of COVID-19 disease between the groups randomized to receive the vaccine and the control, and that there is some minimum sufficient period of follow-up. So for example, if you had very few endpoints and you declared a result, you could have an apparent high vaccine efficacy, which turned out later not to be the case. So you could have a report of 60% efficacy where the real efficacy could be as low as 10 to 20%. By having more endpoints, we can be more comfortable that the lower bound of the confidence interval is at least greater than, say, 30% or so. So this is really an important feature. We're going to have a lot of phase 3 trials that are reported, and we always have to look at the confidence interval as well as the apparently reported vaccine efficacy. let's always bear in mind that we only know the real vaccine efficacy much later when the vaccine has been given to many more people. We don't want to inappropriately declare a winner based on one of the early results. Similarly, we don't want to get too disappointed if one of the early trials turns out to be less positive than we hoped for, because there are many more arrows in our quiver in terms of the global portfolio. So I'm pretty confident that at least some of these vaccines will turn out to be sufficiently efficacious. We also need to be very careful about safety, and we only ever have limited information on safety, and it's good to see some of the pauses that have occurred with some clinical trials, because this is normal practice. If something unexpected happens that may or may not be related to vaccines, we pause and we reassess and we see the situation. And it's also very important that we're able to evaluate the other vaccines that come through later, because as I said, there's no reason to believe that the first vaccines that are tested are going to be the best ones and will necessarily be the ones that will be used at very large scale. So we need to find a way to test the other ones coming through, and many others will come through. We also need to be able to have information on the duration of protection, which is why, in general, it is better to continue with follow-up so that we have at least, say, 12 months of follow-up from these trials. And finally, on this slide, I think it's very important as scientists to be open about the fact that there is what we know and what we don't know for SARS-CoV-2. This is a very new virus. There's a lot that we don't know. And so let's continuously reassess any assumptions that we're making in investment of public funds and testing these vaccines as we proceed. That's going to maximize our chances of success. Now, I think we have another speaker from CEPI who will talk more about the vaccines pillar of the ACT Accelerator, but I want to give you a brief overview of the Access to COVID-19 Tools Accelerator that has been launched by the multilateral community to reduce COVID mortality and severe disease and enable development and equitable access and delivery of 3 different classes of medical products, so vaccines, therapeutics, and diagnostics. And vaccines are very, very important, and we fully support the vaccine development efforts, but let's not put too much emphasis on vaccines over treatments and diagnostics, because we absolutely need these as well. And let's always, as we do at WHO, think about how more broadly this work can link to and support health systems strengthening, reduce the burden on health systems, and more broadly restore societies and economies in the middle of this crisis that we're all experiencing. So this, at a very high level, is the ACT Accelerator. The vaccines pillar of the ACT Accelerator, also known as COVAX, I have laid out 4 very broad elements here, and our speaker from CEPI will again go into more details, but broadly, CEPI is in the lead for supporting vaccine R&D and manufacturing scale-up at risk, and this is a very positive development at the moment, that you cannot wait until you find out whether the vaccines work in phase 3 trials before investing in the manufacturing scale-up. Otherwise, we will have very long delays before access. So that is happening thanks to the generosity of the international community. We are providing guidance at WHO on the desired profiles of vaccines, guidance for data generation for the community, as well as our core role in normative policy development, providing recommendations. We have a group called SAGE, the Strategic Advisory Group of Experts on Immunization, which will be critical in reviewing the evidence from these vaccines once the phase 3 trials have occurred, to make recommendations that everyone can trust as we move into delivery of vaccines. And then pooling resources to enable equitable access is on my next slide. The COVAX facility, and I'm ending here, is a critical part of this effort, led by Gavi. There are 2 main aspects to this. There are 78, as of the date I'm giving this talk, higher income countries that have joined the facility that will be self-financing, pooling resources. And then there are also 92 lower and low middle income countries that will have access to support for provision of vaccines, so that we don't end up in a situation where it's many people in just a few countries that receive vaccines once we know which ones are high quality, safe and efficacious, but we can have a rational, equitable distribution of vaccines for those in need around the world. And I'm very pleased to say that already we have a substantial contribution from many donor countries into this Gavi advanced market commitment, but we need much more, and that's going to be a critical element over the next few months. So I'm going to wrap up here. I think there's another speaker after me, and I look forward to taking some time in the panel discussion that I believe is going to be scheduled after the speakers. Again, thank you for this invitation to the World Health Organization.
Good morning, good afternoon, good evening. It's a great pleasure and honor to be here with all of you. We'll be speaking today about the really critical question of access to COVID-19 vaccines. I think as many of you are already very well aware, vaccines really don't have any impact unless, of course, they reach people. And I think this is really the key theme that I'd like to focus on. Before I dive in, I just wanted to declare that I have no conflict of interest to disclose. I also would like to thank my research assistant, Anna Bazruki, who provided very valuable assistance for preparing this talk today. So let me dive right into the introduction. Access to vaccines is, of course, critical for not only individual health, but also population health, and also restoring economic activity and the normal functioning of societies. This is why, of course, there has been so much attention put on who will get access to a COVID-19 vaccine. I think it's important to take a step back and think about prior to this pandemic, how prepared were we at the global level to, in fact, ensure that all countries would be able to access countermeasures, as we call them, in the event of a pandemic? And the answer is pretty clear, not very. So there were no and are no clear international obligations or arrangements to ensure access to vaccines, diagnostics, and drugs, with two important exceptions. The first is pandemic influenza, so one pathogen, one very important pathogen, for which we have a framework that would ensure 10% of vaccines that are manufactured will be dedicated to WHO, which would then allocate them to other countries. This has not actually been tested in an influenza pandemic, however. The second exception is the 2017 creation of the Coalition for Epidemic Preparedness Innovations, known as CEPI. It's a global R&D fund supported primarily with public money and also philanthropic money. And the purpose is to invest in the research and development of vaccines for pandemic potential. The creation of CEPI was very important in jump-starting all the way back in January of this year, research and development towards a COVID vaccine. Fast forward to May of this year, where we had a number of very important political statements made by world leaders calling for a COVID-19 vaccine to be made available as a global public good. And essentially what that means is that it would be openly and freely available to all people around the world. I think it's fair now to take a step back and ask, 5 months later, how are we doing? So you can see here on the screen some data that we've collected and analyzed regarding who, in fact, has already secured access to vaccines. And what you can see on the left side of the screen is a number of countries that have managed to get access to vaccines from a number of different companies. Those are listed in the legend on the right-hand side. And some countries have done better than others. You could say the line that governments are trying to cross here is that line 2. And that's because we need, for most of the candidate vaccines, 2 doses per person. So this is the number of doses per capita that's already been secured. You can also see on the right-hand side of the table that a number of middle-income countries, especially those that have the capacity to manufacture vaccines, have also managed to secure supply and technology transfer agreements, many of them with just 1 or 2 candidates. And then at the very end of the lineup, you see COVAX, which I'll come to in just a minute. This is the multilateral initiative. And so far, unfortunately, only a very small proportion of global supply allocated or committed to COVAX. What I'd like to do now is show you the same data, but this time we look at it across companies rather than across countries. And again, on the left-hand side, we've listed first the companies that have products that are at the furthest stages of development, phase 3. And you see move across the screen, moving up to phase 2, 3, phase 2, 1, etc. So the ones on the left are the ones that we expect to cross the finish line earlier. And a couple quick observations that I think are quite striking. One is, of course, the AstraZeneca-Oxford candidate vaccine has by far made the most commitments to supply and to technology transfer across a pretty broad range of countries. For all of the other candidates, we have a much lower volume that has been committed, and usually just to a handful of countries. I should mention that, of course, at this point in mid-October, we still don't know which vaccine is likely to be the safest, the most effective, the most affordable, or to even cross the finish line at all. So there's a lot of uncertainty as to which of these candidates will actually reach people, will reach the market. I should also say that these are estimates that we've calculated based on publicly available data. I imagine we've not captured everything, but we think that the overall conclusions are still accurate and that they still hold. Finally, one last comment on this slide, which is that you can see a number of the companies that have a star next to the name. Those are companies that have received money from CEPI. And because CEPI has a mission and a mandate to ensure equitable global access to the vaccines that they fund, these are the companies that we would expect to allocate supply and to sell that supply at an affordable price to different countries around the world or through the multilateral system. At this date, it remains to be seen whether or not that in fact is what will happen. This is the same data. Again, you can see on the left-hand side the companies, and on the right-hand side the flow of vaccines going from companies to a number of different countries. And we can draw the same conclusions. A handful of countries really getting most of the supply, with a few other countries manufacturing down at the bottom of the right-hand side. So what are some key points or observations that we can make based on the data so far? I think first, plenty of evidence of vaccine nationalism. Certainly many countries trying to get as much vaccine as possible for themselves first. But also there has been important evidence of vaccine multilateralism. CEPI, Gavi, and the World Health Organization are jointly leading an initiative called the COVAX Initiative. And COVAX has a couple of key features. As of this date, it has firm commitments from 171 countries to participate. They represent over 90% of the world's population. And the idea basically is that COVAX allows them to pool risk, because again, we don't know which vaccine will be successful, to divide up the piece of the pie that they get access to in an equitable and ethical way. And it offers a channel to subsidize lower income countries who might not be able to cover the full cost of the vaccine. The key question is, of course, how big is the slice of the pie that countries participating in COVAX will be dividing? The target is to reach 2 billion doses, is to secure access to 2 billion doses by 2021, and to cover 20% of the population, the most vulnerable priority groups in all participating countries by the end of next year. As I mentioned, a key question that remains unanswered and is really critical is how big a slice of the global supply of vaccines will in fact be available for COVAX. And even within that slice of the pie, will some countries get a larger proportion than others? In particular, will countries that are self-financing receive a larger proportion than those who are relying on donor subsidies? And this remains to be seen exactly how this will pan out over the coming months and year. So overall, what we see is a situation of vaccine nationalism and multilateralism operating side by side, oftentimes in direct tension with each other. Also, at least in my opinion, offering a reason for hope, but also operating in an extremely complex environment, extremely complex supply relationships, where it remains still very uncertain which vaccines will be successful, who will get access to them, at what price. Let me offer, I think, a light array of potential sunshine here, which is that it's possible that we will, in fact, have a much larger supply of vaccine than was initially estimated. So if we begin by looking up in the right-hand corner at the AstraZeneca-Oxford candidate, again, this is the candidate where we've seen the most supply deals struck already. You can see this green slice, the small green slice that indicates 300 million doses out of a total of 3 billion. So this is a very, very small proportion of the overall pie that is now dedicated to COVAX. A number of wealthier and developing countries make up the remainder of that pie. So a key question is, when we start looking at the vaccine candidates at the bottom of the slide, all of the blue pieces of the pie are basically not yet allocated. And so a key question is, how much of that blue unallocated pie is going to end up going to COVAX, and how much of it will end up going to countries with the greatest ability to pay or the greatest degree of political influence? And this is really one of the key questions we'll have to watch quite closely. Again, we don't know which of these candidates will ultimately be successful. Up to this point, I've been largely focusing on the big Western firms, on the Western vaccine candidates, but it's important also to highlight that 4 out of 10 of the 10 vaccine candidates that are currently in the latest stages of development are in fact being developed by Chinese firms or organizations. And we have had a harder time finding data on which countries will be getting access to any of the Chinese developed vaccines, but we can get an idea of that if we look at where those clinical trials taking place. And what you can see on the right-hand side of this slide is, of course, a relatively long list of countries that have already struck agreements to collaborate on R&D, and most likely will also have agreements for access to vaccines and potentially for technology transfer. And so what you see overall is, of course, a very complex landscape in which countries, whether low, middle, or high income, are using all of the means at their disposal to try to get access to vaccines. It's an extremely complex spaghetti bowl of agreements. If we think about what is driving and what will determine at the end of the day who gets access to COVID-19 vaccines first, it's a complex mix of a number of different drivers, including national security considerations, commercial interests, the political interests of various countries, and as well as their industrial interests, and then somewhere in there, of course, also health and ethical considerations. The experience with vaccines has very important implications, not only for vaccines, but also for therapeutics. We expect in the coming weeks and months to have much more robust evidence regarding effective therapeutics, but these will be scarce. Supplies of monoclonal antibodies will be scarce. Supplies of remdesivir are already scarce. There will be other products, hopefully, that demonstrate safety and efficacy as therapeutics. And so one of the key questions is, what can we learn from the vaccine experience so far that will help us to ensure equitable access to therapeutics as well as to vaccines? And I think there are two. The first is that if we want equitable access, we have to agree on ways to divide up the global pie in a manner that is transparent and that's based on ethical and public health principles. The second is that we need to not just think about how do we divide up the pie, but how do you enlarge the pie as quickly as possible? And you can make that pie bigger through technology transfer, through the sharing of intellectual property and know-how, and through investment. And the larger we can make the pie, the easier it is to, in fact, agree on how it should be divided. Last but not least, if we think about how can we build back better beyond COVID, perhaps if we can imagine a post-COVID world, I would say we have to pay much more attention to clarifying and establishing norms and rules and institutions for global access to countermeasures. This has to be part of the reform agenda. It's an issue that has been largely neglected by the international community in debates over preparedness for outbreaks up until this point. With that, I conclude. Thank you very much, and I look forward to the discussion.
My name is Jeff Lazarus, and the title of my talk is Vaccine Hesitancy. Until we understand public opinion, we cannot hope to change it. The public is a vital information source for decision makers in pandemics to inform response efforts and understand challenges to disease control. Health communication from government must be flexible to adapt to pandemic stages, but is often challenged by an infodemic and politicization. Communication should be two-way, both informing the public and promoting mutual understanding and acceptance. Trust in government and health officials can improve public cooperation with pandemic measures. Now, with this in mind, we developed COVID Score, a validated tool measuring perception of key government pandemic responsibilities based on the World Health Organization's Health Systems Framework. Key government responsibilities include clear and accurate communication with the public, access to COVID-19 testing and treatment, continuity of health services, including mental health, social protection, and assistance meeting daily needs. 13,000 people were surveyed in 19 countries in June 2020. Scores ranged from as low as 35 out of 100 in Ecuador to 80 in China. Scores were strongly associated with measures of government trust. They were moderately associated with COVID-19 sickness and mortality, and no association was found with World Bank country income level, Human Development Index score, nor degree of democratic governance. It's important to understand each score in its own country's context and not merely compare one country to another. Globally, higher scores were observed for the perception that the government was cooperating with WHO and other countries and produced accurate reports and statistics. Lower scores were observed for items assessing mental health service provision, protections for vulnerable groups, and assistance meeting daily needs. Items which performed near the average assessed continuity of routine health services, free access to COVID-19 testing, and government communication about the pandemic. And remember, all of these scores are those as reported by the general population in the 19 countries where the survey was undertaken. Along with the 10 questions we asked as a part of COVID score, we also asked one question about vaccine uptake. If a COVID-19 vaccine is proven safe and effective and is available, I will take it. And here you see scores range from as high as 88.6 in China to as low as 54.8 in Russia. In most of the 19 countries, willingness to accept a COVID-19 vaccine is insufficient for possible community immunity, with 16 of the countries having under 80% of the population willing to take the vaccine. Public health interventions should be designed around trust-building concepts. These include transparent, evidence-informed policy and clear, accurate communication. Older age groups were more likely to accept a vaccine according to our survey results. Those earning above $32 a day are more likely than those in poverty to accept a vaccine. Higher levels of education were more likely to accept a vaccine, while those reporting sickness with COVID-19 were no more likely. And those who reported trust in government were more likely to accept a vaccine. In conclusion, we found strong evidence of potential COVID-19 vaccine hesitancy in a 19-country survey we carried out at the end of June 2020. This hesitancy is associated with a lack of trust in government. Where trust was higher, vaccine confidence at a country level tended to be higher. Increased effective communication from government and the health sector can help the public understand the importance of vaccination. There's a need not just for increased public trust in vaccines, but for increased public health community understanding of the dimensions of COVID-19 vaccine hesitancy. Without this, we cannot develop the messages and tools needed to effectively control the COVID-19 pandemic and protect the population. Thank you. I'd also like to thank the colleagues involved in this study, as well as members of my team at IS Global and the Convince Coalition for the opportunity to present preliminary results at their Wilton Park meeting earlier this year.
Hello, I'm Kate O'Brien. I'm the director of the Department of Immunizations, Vaccines, and Biologicals at WHO. And I'm going to follow on from that last presentation and talk about going from COVID vaccine efficacy trials to actual public health interventions. So this is really about speed, scale, and access. So as Vasi presented also, the goal of the Access to COVID Tools Accelerator is to reduce COVID mortality and severe disease. Through this accelerated development and equitable allocation and scaled delivery of not only the vaccines, but also the therapeutics and diagnostics. But focusing on vaccines, that quantitative goal is to deliver 2 billion doses by the end of 2021. So there's this complex system, as all of you appreciate, to go from clinical trials, which I've schematically shown in the blue and white checkerboard circle in the background, to actual impact on individuals and communities. And the things that need to happen are circle around the evidence from the clinical trials, but have to converge through coordination and through resources, all to access communities and to get vaccine delivery. I'm not going to go through all of these elements. There are several of them that I want to focus on that include the policy the regulatory approaches, some of the delivery approaches, demand, and healthcare workers, along with innovation. So the first thing I want to say is what we're all trying to do is absolutely unprecedented. This is a figure that shows by year and in different colors vaccine antigens that have been introduced into the immunization program over the past 3 decades. You can see in blue with an arrow the initiation of Gavi support for hepatitis B with some acceleration of hepatitis B introduction. Then in black, you see one curve, which is IPV, so injectable polio vaccine, inactivated polio vaccine, with a really abrupt change. And this was the fastest introduction that we've ever done worldwide of a vaccine whose recommendation changed in 2013. And over on the right is a projection of what we're aiming to do with COVID-19 vaccines. So completely unprecedented in the history of vaccination introduction. And this is layered on COVID-19 interruptions in immunization. This map of the world shows the immunization campaigns, not the routine immunization program, but the campaigns that take place as a backstopping for the routine immunization program that were paused over the course of the past few months. And in green, some of the countries that have started to recover their campaigns. So we're also envisioning a massive introduction of vaccines layered on an interrupted program. But the program is coming back worldwide, and these photos show you some examples of the kinds of structures and changes in the vaccination program that are being instituted to safely assure that healthcare workers can do what they need to do, that communities can be confident in coming for vaccination services, and that the life-saving vaccines that need to be distributed are done so with safety and effectiveness. There are 3 components that inform a country being able to formulate an in-country vaccination strategy, and ultimately it is countries that are responsible at the center here for final decisions on in-country policy, the allocation of vaccines that are in short supply, and the strategy for vaccination. From a global perspective, there are global supporting entities on an allocation framework, establishing the way we're going to envision allocating vaccines in a fair and equitable manner across countries. Then a policy formulation support from SAGE on guidance and specific policies on vaccine products, and then the regulatory safety and monitoring component. And I'll just show a few slides describing each of these at the global level. So WHO has been responsible for developing, vetting, and finalizing an allocation framework for what will be vaccines in short supply, as Suri was talking about. This allocation framework and mechanism, it has been based on extensive country input, and the goal is to protect public health and minimize the societal and economic impact by reducing COVID-19 mortality, and I'll add severe morbidity to that. In the first phase, shown on the 2 first steps on the left-hand side, participants, and we refer to participants, which really means countries or economies, would receive doses proportional to their total population. And this would be to cover 20% of the population in total. The first part, about 3% of the allocation, is envisioned for those highest priority social and healthcare workers, and the next 17% for high-risk adults, likely to be those that based on age or comorbidities. And on the right-hand side, after the 20% is allocated, participants, meaning countries or economies, would receive doses to cover more than 20% of their population, with the speed and ordering of which countries receive vaccine in which order, potentially to be adjusted according to the vulnerability and COVID threat of those countries, if we're still in severe supply constraint at that point in the allocation of vaccine. Moving on then to the SAGE policy processes, there are 3 documents that are envisioned from SAGE. 2 have been released already. The first, and are available on the WHO website. The first is values framework, which specifies the values. There are 6 values that are specified in this framework that would be the lens through which any proposed prioritization of specific populations could be assessed. So these specify the principles, the objectives, and outline the target groups of a COVID-19 vaccination program. The second document is specific roadmap, specific guidance on the actual prioritization of target populations under different supply situations and under different epidemiologic settings. This was released at the beginning of October and has a detailed analysis according to priority populations seen through the lens of the values framework. And the third that is yet to come is the actual policy recommendation on specific COVID vaccines once they're registered. And it would consider product-specific data and attributes, and with consideration of the regulatory approval process. So really working hand in glove with an emergency use listing or a full registration of products. The third element is the global regulatory alignment. And we clearly see the need for context here and the need for this alignment because of a rapid globalization of supply chains of medical products and technologies and a real patchwork of regulatory requirements and processes around the world. And then very uneven global capacity for regulatory processes, which means that there are some duplicated efforts for a given product submitted to agencies in different countries. And this adds increased time and cost to bring new products to market, meaning there's also barriers to the assurance of vaccine safety and efficacy and the efficient development of products. So this context that we're in really calls for much greater scale of cooperation, and a large number of vaccines that are under development in a large number of countries would really benefit from that. So a need for multilateral strategic coordination of regulatory efforts, which WHO is leading on, and including the recent developments, which are the release of a public consultation on the considerations for COVID-19 regulatory processes, and a recent issuance of a call for expressions of interest to manufacturers for us to get a signal from them of their interest to submit a dossier on emergency use listing or pre-qualification. Moving quickly to vaccine safety, I won't go into a huge amount of detail on this, largely because of time, but suffice it to say that for this vaccine, for all kinds of reasons, the concern of the public and certainly the assurance of regulators and vaccine trialists and epidemiologists and the whole vaccine ecosystem is that vaccine safety is paramount, and that there will not be any compromising on the data on vaccine safety, but that monitoring of vaccine safety in the post-use period is going to be critical. So WHO has held a workshop on the vaccine safety ecosystem to map the requirements in the context of a rollout, determine who's doing what, and identify the gaps and duplications so those gaps are being filled now. There is our Global Advisory Committee on Vaccine Safety that will meet at the beginning of December to review the vaccine pharmacovigilance preparedness manual that is about to be issued, and update the list of adverse events of special interest based on the latest developments from efficacy trials, and agree on this global mechanism for vaccine safety monitoring in the post-deployment era. And then there will be global webinars in the week of December 14th on the preparedness manual. I want to move quickly to confidence and demand. And we've all been reading on a daily basis the uncertainty and the decisions that people are already making, or apparently are making, about a vaccine we don't even have yet. I want to reflect that this is data from global surveys that we've been doing on a periodic basis over the past several months. This one, the results from May, of demand disruption for routine immunization services in the context of COVID. So this is not for a COVID vaccine. This is for our tried and true vaccines. And you can see that over almost 75% of countries have a disruption based on demand. And that is true in all regions of the world, shown on the lower part of the slide. So this is going to be a major hurdle to overcome in deployment of COVID vaccine, given that we have uncertainties around demand, even in our regular vaccines. I also want to speak about the health workforce that is going to have to deploy these vaccines. On the left-hand side, you see the pre-COVID situation, and this is a schematic. This is not to scale, but the availability of healthcare workers to provide essential services, and there is a global shortage to actually deliver essential services. As a result of COVID in the middle, we know that those shortages maintained. Some healthcare workers have succumbed to COVID itself. There are healthcare workers who are off work because of infections, and many others who have been deployed for the COVID response, reducing the number that are available to provide essential health services. And on the right is what we project that added to this will be those who will be deployed for the vaccination service deployment of COVID vaccine. So this is also a major area that needs attention and needs planning worldwide. I also want to touch on gender, although we know from the epidemiologic analysis of COVID itself that men have a greater risk factor, are at risk for death more than women, there are many ways in which gender plays out both for men and for women in a COVID world. And this has been documented in many different ways, including the economic impact and differential economic impact. But I do want to pull this together with healthcare workers. So globally, 70% of health and social care workers are women. A much smaller proportion are leaders in the global health sector. And on the bottom of this slide, you see two examples of countries where COVID-19 infections of healthcare workers are disproportionately found among women compared with men. So as we anticipate the deployment of the vaccine, who needs the vaccine, the data from the vaccines on whether or not they can be used in women, especially of childbearing age, who don't have demonstrated contraceptive measures, there are many issues around gender that are likely to play out in the deployment of vaccines and the equity around this. 2 points I want to make on innovation. This is an opportunity for the immunization enterprise, sort of writ large, to take some leapfrog steps forward. One of those is the idea of an electronic vaccination card that would capture the interaction between a provider and a patient, potentially certified by a central authority if certification of vaccination in some countries or for other reasons is necessary. And this would, there are clearly technologies to do this, and introducing this into vaccination programs wherever this could be introduced would be an enormous step forward for the immunization program, which does struggle to follow and track immunization status in the routine immunization program. A second innovation that I want to speak about is advancing on the use of barcodes to improve coverage, to improve stock management and immunization safety. There are, pretty much everything we encounter in our daily lives, including movie tickets, have barcodes on it. I think it might be interesting for you to know that vaccines don't have barcodes on the primary vial. There are secondary packaging shown in the lower right-hand corner where there will be a requirement through UNICEF procurement for all vaccines to have barcodes on secondary packaging as of the end of 2021. Lots of reasons why barcodes are of high use, and if we could progress on that, it would be great. Last couple slides, I just want to give some information on what is happening at the global and regional level to establish country readiness and country delivery coordination. There is a very substantial partnership that has taken hold as of beginning in about May or June. The country readiness and delivery work stream includes 6 technical areas on data monitoring, communication, advocacy, and training, coordination and implementation guidance. And in the implementation guidance area on vaccine introduction, on demand, and on supply logistics. There are, I show on the right-hand side, the core partners, both at headquarters levels and at regional levels, WHO, UNICEF, and then along with Gavi, the World Bank, the Gates Foundation, US CDC, IFRC, and a larger number of partners joining this coordination task force. And the task at hand right now, the urgent task at hand, is for every country to go through a vaccine introduction readiness assessment. And going through a checklist which has these these 9 elements that are shown on the right-hand side, going all the way from planning and coordination through resources and funding, on through regulatory, service delivery, training and supervision, surveillance and monitoring, the logistics and cold chain, safety and surveillance, and advocacy, mobilization, and communication. This is really a roadmap for countries to assess their readiness in all of these areas and support countries to self-monitor their readiness. It's not a detailed operational guide on how to achieve that readiness. However, that detailed operational guide will be released at the end of October, and it is a guidance for national vaccine deployment plans and will form the basis for countries to have a full-on plan of being able to deploy vaccines. So my last slide is just to highlight that looking at countries from that big overarching area, we do have to keep in mind the issue of equity. And we believe that there are 4 major areas and probably more where equity needs to be addressed. Those who are in remote rural settings, the urban, densely populated settings, areas affected by conflict, and then I've mentioned already gender. So this huge enterprise that we have to assure that everyone everywhere who can benefit from this vaccine, which does not necessarily mean immunizing everybody in a country, but assuring that there is equitable allocation of this vaccine and that people are not left out on the basis of access or wealth. So I'll end there. The opportunity, in my view, is now. And there's a call for all of us to do put our oars in the water and go at speed, scale, and access. Thank you.
To thank all the speakers. We are now going to enter into the Q&A session. I would like to start by asking the important one, and to Surimun, what do you think we really need to do to ensure equitable access, particularly in the context of the fulcrum of inequities and inequalities between and within countries? Surimun, over to you.
Hi, thank you. Can you hear me okay?
Yes.
Yes, wonderful. Thanks. It's a great question. And I think one of the key takeaways from this really excellent set of presentations from the R&D process through to reaching, going down to the last mile. I'm going to focus my attention on the dynamics at the international level. I think should be congratulated. I think it's a real beacon of hope. I hope that it will be able to deliver. But in order for it to do that, you actually need, for a number of other countries, particularly those who are wealthy and those that have production capacity, by different rules. I think we need governments to say we will refrain from trying to consume more than our fair share of vaccine supply. We will not first cover vaccines to be allocated to countries. And so far, we have not seen that kind of restraint. That's on the political side. So I think we need to really, but not only in the North. I think for the other piece of the puzzle that I think is really important is to have much more emphasis and funding on technology transfer, on open sharing of data, on trying to expand the overall size of the pie. And we need good information on that. But there's no point in having everybody fight for a small pie. That's not going to serve anyone's needs. So I do think that in addition to money on the table, in addition to fair allocation frameworks, equitable allocation frameworks, we need to make that pie bigger. And we need the biggest eaters at the table to wait until everyone has had a bite. Over.
Thank you very much. And to Professor Jeffrey Lazarus, how do we deal with the trust deficit that you have outlined in your presentation? And how do we use that as an opportunity to strengthen our communication, health communication? Over to you, Jeffrey.
Thank you. Well, I think we need to call on, all government leaders, all politicians, policymakers, and health authorities to really carefully explain the process and assure the public, of the safety and effectiveness in addition to the efficacy of vaccines. We need better communication. We need to listen to the concerns of those who are hesitant to take a vaccine, who are openly opposed to a vaccine, and try to mitigate and respond to them rather than shunting off their views.
Thank you very much. How do we move 2 billion doses of vaccines, addressing these inequities that exist, weak health systems, particularly in resource-constrained settings? So, Kate, can you tell us, practically, how is that going to happen? We know the health systems are weak, and now we're going to put 2 billion doses on top of the existing infrastructure. So can you share insights with us?
So I think the planning that's taking place is, first of all, we have to remember that there is an infrastructure, that immunizations have the farthest and deepest reach of any health intervention that we have, and reach into the furthest parts of every country. So that's, I think, the first thing to remember. The second thing to remember is that depending on the doses that are going to have to be administered, it will be either a 1 or a 2 dose regimen, which is going to certainly require us accessing people who we don't normally access. This is a massive opportunity for integration. This is a massive opportunity for actually pulling in primary health care and applying that into countries that have otherwise perhaps not been able to make those moves yet. And then I think the third thing to say is that there is an infrastructure that sits there, both a cold chain infrastructure and a healthcare worker infrastructure. I think the biggest concern is we don't want to simply move that infrastructure over to COVID vaccine. We have to maintain the other essential services while all this is going on. So the planning for the healthcare workforce is going to be really critical, and that is going on now, along with new opportunities for training to allow a distribution of a greater number of people to be actually able to deliver vaccines.
And lastly, to Vasi Murthy, can you just tell us, Anthony Fauci was cautiously optimistic. Now, how can we ensure that we continue with the public health measures in advancing prevention, whilst we still invest in vaccines, diagnostics, and treatment? And how do we address the balance?
Thank you. I think it's really incumbent on all of us to take a holistic approach to how any individual intervention fits in with a package of public health measures. So we have to make sure that the understandable excitement around COVID-19 vaccines, and I'm as excited as anybody else, just to make it clear, it has to be taken in the context of and it's really a false dichotomy to say, what is more important, in my view, between various different types of interventions. We absolutely need options for physicians who are treating patients in hospitals. We all know about the major burden to health systems of hospitalized COVID-19 patients and the morale issues that we're facing with healthcare workers who are having to deal with repeated waves. So there is a very major need for additional treatment options. And there, I'm equally optimistic as I am for vaccines. And I would just like to say that for therapeutics, we are now moving into a new phase where initially we really were evaluating only repurposed agents that have been developed for other viruses. Now we have multiple agents that are being evaluated that have been developed specifically for SARS-CoV-2, including monoclonals. And we're going to face similar issues with linking R&D evaluation and access with monoclonals as we are in vaccines. And I think that's an area that actually needs more focus than we've had now. Unfortunately, we don't have exactly the equivalent to CEPI and Gavi in the therapeutics area. And I know that there are many discussions about this. Those are very important. Diagnostics are actually totally foundational to all of this. So we somehow have to maintain the optimism for vaccines, but understand that they're part of this much broader system. And finally, before I stop, I think there's another very important issue with the vaccines that we haven't touched on in the panel yet, and that's the link between the results from the phase 3 trials and the regulatory processes, licensure and policy and delivery. I think there's a lot we can learn from what has happened in the therapeutics arena there, and some things that we should avoid. I mean, we should not be making decisions based on press releases. And I think we have to be very cautious about the way that the interim results are reported and are acted upon. There are good reasons why we need to continue with the trials until we have really robust data from the trials. And although we're trying for the right reasons to accelerate the timelines as much as we can, there's only so far you can go in accelerating the timelines without having an adverse consequence later on.
Thank you very much. Let's advance prevention and take a holistic approach. But of course, there are regulatory capacity constraints. We've had that. How do we make sure that we build that capacity on the ground? Kate, any insights, or any of the members? How do we build that capacity on the ground?
I think capacity building on the ground is going to come through a number of channels. Well, first and foremost, I do think we have to recognize that more resources are needed for this. Delivery doesn't happen without resources, and capacity building doesn't happen without resources. I think we have to recognize the $12 billion from the World Bank that was just announced a week ago in grants and loans that will support vaccine procurement and vaccine delivery health systems in countries. And that's a major investment towards this. But more is going to be needed. And I want to highlight the CSOs, the community service organizations in this, who are absolutely critical for achieving both capacity on the ground and coming back to the issue of demand and confidence. And I don't think we should underestimate that demand and confidence hurdle that we're going to have to work through and not jump over. So getting capacity on the ground and within ministries, within communities, is really a multi-dimensional, multi-institution resource and capacity building exercise that needs to be invested in now if there's going to be the ability to actually deliver these vaccines.
Thank you very much. I would like to take this opportunity to thank the presenters and the audience, the participants, the viewers from all over the world. Thank you very much. This session is over.